My guest today is Professor Janet Currie, who's Professor of Economics and Public Affairs at Princeton University and the co-director of Princeton Center for Health and Wellbeing. She also co-directs the program on families and children at the National Bureau of Economic Research. Welcome, Janet.
Thank you. Nice to be here.
Yeah, thanks for doing this. So we have a number of papers. It all relates to children, healthcare, and policy and economics in more broad terms. So I want to start with one of your very recent papers, Perinatal Health Inequities in the Netherlands, the Role of Income and Neighborhoods. I was reading through this. Netherlands is not a country that I would have picked to look at disparities, but the numbers are quite striking. So you say here a strong link has been documented between adverse birth outcomes and compromised health from early childhood to adulthood. Hence, policymakers may consider targeting their policies towards specific geographic areas and demographic groups with a high incidence of adverse birth outcomes. So what do you find, and what's the data that you're using in this paper?
Actually, I'm not sure this is my paper, although I can talk about it.
Okay.
Are you certain that it's mine?
Say it again.
Are you certain that it's my paper? Sorry.
I just went to Google Scholar and searched you, and this is one of the things that came up. So I can go to another one.
So yeah, I have a paper on the Netherlands, but it's about maternal depression.
Okay, let's talk about that then. Yeah.
Yeah. Okay. Sorry. Okay, so we have a paper looking at maternal depression, and how you get treated depends a lot on where you live. And this is probably true everywhere, but it's especially true in the Netherlands. Rule that says that you need to be able to, your primary care physician needs to make house calls, essentially. So you have to be close enough to the primary care office that they could conceivably make a house call. So that means that your choice of primary care physicians is kind of limited to people within a certain radius of where you live. Yeah. So we use that variation to predict whether women who are suffering from postpartum depression drugs or not. And then we try and look at, if they get treated with drugs, what is the long-term outcome for, mostly for them, actually. And so what we see is that the women who are treated with drugs tend to stay on them for a long time. So they don't only get them for some short period of time while they have postpartum depression. And otherwise, we don't see very much impact on whether they're more likely to go to work or what their wages are, or even family functioning, whether their households are more likely to stay intact, whether they're more likely to have additional children or not. So we don't actually see a lot of impact on promoting more positive outcomes, but we do see this kind of disturbing tendency for people to just stay on the drugs for a long time.
Yeah, I mean, this is a pretty interesting area, right? So Netherlands being a developed country, two things are going through my mind, Janet. Correct me if I'm wrong. So one is it a well-known indication for people? If it's well known, then the patient will seek treatment. If it's not, and I'm thinking developing countries where it may not be that well known as a condition. And so there are two things here. One is sort of seeking treatment, and the other is diagnosing and then ultimately treating it, right? So So in the Netherlands data, so what do we find? Are people, is the percentage suffering from it always seeking treatment?
So the the Netherlands is also unusual in that most babies are delivered by midwives, but then
Hmm.
midwives are trained to look out for this, and it is a sort of important thing that's known to affect new mothers. So in principle, they should be able to get treatment. What I think is going on is, and and this is well suited for an economist to look at, because the issue is who is the marginal person that's getting treatment. So if it was the case that most people who are very severely ill always got treatment, then the variation that we're using, which is, how much do doctors prescribe, or, how aggressive are they in prescribing, that's mainly going to affect the people who may not be that sick. And so that could be, and then what do they get? They just get this drug prescription, but it doesn't really do that much for them.
Hmm.
And so it may be the case that the marginal people in a place like the Netherlands are not benefiting that much because the most severely ill people are already being treated. So it's kind of a question about where you should draw the line for treatment, and not, should you treat anybody at all. Now, as you raised, I think that in a developing country, the line might be in a completely different place, such that there were a whole lot of people who weren't getting treatment that could really benefit.
And is this a condition that is easily treatable? No, I don't know much about it. So once you get to the clinic, the physician can take care of it, right? I mean, it's just pretty easy. I mean, it's almost like a depression type issue, right?
Yes, it's kind of a hormonal issue, really. So it should resolve eventually on its own, pretty much on its own. But the drug treatment can be helpful, and therapy is helpful. Therapy and also social supports. If the mother just feels terrible, having somebody come and help look after the baby and so on can be very helpful.
Hmm.
So the kinds of supports that you need are not necessarily only medication, but other types of supports also.
So the paper that we talked about first. So there's sort of an economic gradation, right? In some sense. So if you are economically well off, I'm just speculating here. You have a high chance of getting into a clinic and getting treated and getting better. If you're not economically well off, this is not something that might be prioritized if you're budget constrained, right? Is it?
So a lot of European countries, it's not, the budget constraint isn't the biggest constraint, just because they have socialized medicine. And so in principle, everybody who needs care should be able to get it. You do see a lot of cultural barriers.
Hmm.
So now in a lot of European countries like the Netherlands, if you we're going to make a generalization about who is poor, it would often be people who are recent immigrants, particularly people who are recent immigrants from poorer places. And so those groups, in addition to maybe not having the same information as everybody else does about the benefits of care, might even have cultural views that certain care is not appropriate or not
Hmm.
desirable. And so I think the barriers there are much more along kind of recent immigrants, non-immigrants lines now.
Hmm. I mean, there's a bit of stigma associated with it, I would imagine. I mean, you talk about in other papers that, any sort of depression or mental related things in strong cultures, there's always a stigma associated with it. I don't know if you looked at the data in the US, where do we stand on this
So
problem?
this
Yeah.
is a very interesting question, I think, because One of the things that we hear a lot about is how there are these growing rates of mental illness.
Yeah.
And yet there's a number of things going on which all sort of inspire to have more reporting of mental illness. So one of them is just lower stigma. If you have lower stigma, then you have more people going to seek care, and people are, not afraid to say that they have depression or a mental health problem. So more people will be reporting that they have these problems. And so kind of paradoxically, the reduction of stigma could make things seem like they're getting worse when they're really getting better, in the sense that people are getting care that they need to get. So that's one of the things that might be causing an increase in rates of certain types of mental illness. Another one is just that we've really changed screening guidelines. And so, for example, in 2011 in the US, the Preventive Task Force said that you should screen all women and girls over 12 for depression. And when they did that, you saw increases in reports of suicidal ideation, which is one of the things that depression screeners ask about. There was quite a sharp increase for girls, but not for boys, because girls were getting screened and boys weren't getting screened. Then a little bit later on, when the ICD-10 was adopted in the United States, clinicians were told, if somebody has suicidal ideation as a secondary diagnosis, you should record that. Right? If you don't record it, it's not going to get treated. So you should record it. And then you see this big increase again in that diagnosis following that recommendation. So you have more screening, like more looking for things, less stigma, and that could be one of the things that's driving higher rates. And then actually there's also this issue that I think the public doesn't really understand, which is that the experts keep changing the definitions.
Yes.
So when you read about autism, for example, there used to be 5 different things that were sort of related, pervasive developmental disorders, Asperger's, and so on. When they did the DSM-5
The spectrum,
revision, then they just said everybody's on the autism spectrum. So now instead of 5 smaller categories, we have one big category. And when people look at that, they say, oh, wow, look, autism rates are going through the roof. And part of that is just the change in the definition.
Yeah, so I wasn't going to go into this first times, but so you have I think you have, this is your paper. To what extent are trends in teen mental health driven by changes in reporting? Is that yours?
Yes.
Yeah, so this is sort of related issue, right? So you say here rising reports of suicidal behaviors in children and adolescents have led to the recognition of a youth mental health crisis. However, reported rates can be influenced by access to screening and changes in reporting conventions, as well as by changes in social stigma. Yeah, so as you say, when experts change the standards, it creates a lot of confusion. And it creates a lot of research, typically. And you say, oh, all hell is going to break loose here because, look at this big peak in 2018 or 2017 or whatever. You have to sort of step back and say, what did we measure in 2016 and what are we measuring in 2018, right? That is the problem.
Yes, exactly. So I think it's actually quite difficult to say what the trend. I think it's fair to say that there's a crisis. The big question is it a new crisis? And one reason why that matters is because if people think, oh, this is just a new thing that happened within the last 10 years, then they start looking around and pointing to like, well, what else has changed in the last 10 years? It must be something to do with social media, or it must be this, or it must be that. Whereas if we always had this crisis, say going back to the 70s, when the US government put out a report called the Youth Mental Health Crisis, right? If it was always a crisis, then it's not so obvious that it's being caused by something that just happened recently.
Yeah, so I was thinking, Janet, I don't know if I really understand this. So rates of suicidal behaviors, including self-harm, attempted suicides, and completed suicides. Without knowing much about it, I would say that completed suicide is sort of a solid data, right? I mean, um, the other two, self-harm and attempted suicides, could be more affected by reporting, but completed, we sort of know, right? Is that true or no?
Well, no, I think not even that is true. I do think it's more solid, but things like stigma matter with that kind of reporting, especially with children. You know, if it's not completely clear, like there was no note or something like that, things could still be recorded as an accident, maybe partly out of deference to the family,
Oh,
if the
yeah.
family doesn't want there to be discussion. So, yeah, I don't think it's as completely cut and dried as one might think. And another thing that makes it very complicated is we have so many deaths due to opioid overdoses now, including teenagers. And
Yeah.
those are often not clear whether that was intentional or not.
That makes it really complicated. So your conclusion here that these results suggest that underlying suicide-related behaviors among children, while alarmingly high, may not have risen as sharply as reported rates suggest. So, so I think, yeah, I mean, I think the basic idea here is that, yeah, we have to measure everything, we have to report on everything, but just sort of linearly looking at trends may not be enough. You have to get underneath the data to really understand if there were policy changes, there were reporting changes, and so on, right? That is the underlying issue.
Yes, I think it's an important issue. And as I say, some of this increase could actually be good if it means that people are getting diagnosed and getting some treatment when they weren't before.
Yeah. So I want to go into hopefully another paper of yours. Spillovers and training effects on mental health prescribing for children. Is that yours?
Yes.
Okay. So you say here we use data on all prescriptions filled at US retail pharmacies from 2006 to 2018 to examine deviations from best practice in prescribing psychiatric medications to children. The results demonstrate the importance of spillovers from other doctors in the same area. However, you say individual doctor fixed effects remain extremely important. So if I understand this correctly, the variation in prescriptions given conditions appear to be quite high.
There's a lot of variation. And so in this paper, one of the things that's difficult for a researcher like me is when you see a case in some data and you
Yeah.
see, well, this child was prescribed this or that drug. A lot of the times it's not really up to me to say whether that was warranted or not, right? I don't know this case. And so what we try and do is pick cases where it's pretty clear that certain things. And so what we try and focus on is children who are being treated for the first time for a mental health condition. And then we are also trying to see whether they got something that's FDA approved and recommended, or whether they got a range of drugs which are not approved for children. or not recommended for children. So, for example, you're not supposed to give children long courses of benzodiazepines because those are addictive and they could lead to overdose and so on. But you still see that happen quite a bit. Or you see doctors prescribing things which are not FDA approved for a child, probably because they prescribe them to adults, and so they don't, really know that it's not supposed to be prescribed to the child. So we pick these kinds of cases, and then we try and see what explains the variation across areas and whether that happens or not. And a lot of that boils down to the individual doctor.
Yeah.
And then we see that there's a lot of constancy in what the individual doctor does, which is what we're calling the fixed effect. And then we also see that there is some little influence as well of what other doctors are doing. So if I'm practicing in a certain way and another doctor comes into my area and starts prescribing a whole lot of benzodiazepines to kids, well, then I'm actually more likely to start doing that too. So these sort of bad practices seem to be at least a little bit contagious between different physicians.
Sort of a confirmation bias. So I was in a pharmaceutical company a long time ago, and CNS drugs. I mean, we're talking about children here, but even for adults, it's very difficult to test them. It's very difficult to get the data. There's a lot of variation in them, and side effects have always been a problem in any sort of CNS drug. We understand the body a lot better than we understand the brain still. And as you say here, I think for children, it's much more problematic because oftentimes I would imagine the pharmaceutical companies haven't done the clinical trials. It's very difficult to run a CNS clinical trial in children. I mean, it's almost impossible in many cases. And so, what does FDA stand on this? I mean, the off-label use that you talk about, how do they handle this?
Yeah. Well, we actually make a distinction. I was kind of simplifying it more in what I said to you, but we actually make a distinction between three different types of drugs. As you mentioned, FDA approved drugs. If you're going to limit yourself to using only drugs which are FDA approved for children, that's not very many drugs because most of the time the company doesn't do the clinical trial on children. So then there are another class of drugs which we call sort of gray area drugs, where we say, well, the experts have written some sort of consensus document that says that you could consider using these things in children and that it would be appropriate to use it in these types of situations. And so if somebody is prescribing according to those professional guidelines, that might also seem like a reasonable thing to do. And then the third category is people who are prescribing things which aren't FDA approved and aren't in any professional guideline either. And unfortunately, there's a reasonable amount of that kind of prescribing that goes on too.
Yeah, I think in this paper or another one, Janet, that you talk about sort of the economic, and I don't know if you talk about, sort of ethnic diversity in terms of who gets prescribed what in the cross-sectional data, right? Can you talk a bit about that? I don't think it's in this paper, but yeah.
Yeah. So we actually looked at that using some Canadian data because in Canada, everybody has health insurance, and not everybody in Canada has the same pharmaceutical insurance or drug coverage, but in this particular group that we look at, which were children in Ontario over a period of time, they all had drug coverage as well. So you have a bunch of children, they all have the same insurance, they all have the same drug coverage. And then we look at whether if they're living in a low-income place, or if they were formerly on a program that was providing drug coverage to especially low-income people. So there's two markers for whether they're low income. Then we see that they, conditional on their diagnosis, get treated differently. So the kids who are low income are more likely to be getting antipsychotics, which is kind of concerning. This is antipsychotics with no psychosis. And then the other thing there is that they're a lot more likely to get multiple drugs in the same prescription. So they're kind of being more aggressively medicated than the higher income kids. So we thought that was very striking that was happening in Canada, because usually in the United States we sort of look at the economic inequality as being driven by sort of lack of health insurance or lack of access to care or something like that. And so it seems like we're still seeing people being treated differently medically, even in a place where the access is much more equal.
So that's observation. What do you think is the cause of it?
So what I think is the cause, and this is based on some discussions with some psychiatrists that we had, because we pointed out these findings, and they sort of said, yeah, that's bad, but this happens, and I'll tell you why it happens. It happens because a child is being very difficult in school, and the teachers are at their wits' end, the parents are at their wits' end. The child may be in danger of being suspended from school and not being allowed to go at all, and then the parents have to work and so on. And so if we give these medications, the child will calm down immediately. And then they will be able to stay in school, and their parent will be able to keep working, and so on. So people come to us in these desperate situations and say, please help us. And we can help people in the short term by doing this. Now, of course, it's not a very good solution, because especially things like antipsychotics or multiple drugs, you have a really high risk of side effects. For antipsychotics, the average child gains like 20 pounds and has a risk of metabolic changes. And once they start taking them, they end up being on them for long term. So it's a kind of negative thing to happen, but it's understandable when you think about the whole context. So why would this happen more to low-income people? Because they have less options. If the child gets thrown out of school, they're not going to be able to get the private tutor. They're not going to be able to hire somebody maybe to go around with the child at the school. They can't take the time off of work. All these kinds of constraints that people face.
Yeah, this is so interesting, Janet, and I haven't really thought about this. So, as you say, they have less flexibility. And if you are a parent and you're working two jobs and you have a kid who has some problems, your objective function is to, since I don't have time, I have to sort of aggressively intervene, let's call it. Whereas if I'm economically better off, I don't have to that aggressively intervene. And given that the CNS drugs have very different effects, some of them have very good tactical effects, but a lot of strategic bad stuff. It's almost like a lack of flexibility for the low-income parent, right? That's what's causing it.
Yeah, I think a lack of options maybe is the way to think about it.
Lack of options. So do you see some sort of a policy intervention of some sort that might make it better?
Well, so actually something that I think it would make things a lot better for kids is if there was more interaction between the education system and the healthcare system. So
Yeah.
right now they're really set up in a completely siloed way, and educators aren't necessarily allowed to know what's going on
Hmm.
medically. The doctors often sort of take the view that, well, your health has to take priority over everything, so they don't really care that much what's going on in the school. They're just focusing on the health of the person. So, for a child, being in school is their usual activity, right? So for a child to be healthy, they need to be able to function in school. And I think, it would be better if doctors would think of that as being the same as like, well, can I walk upstairs, or can I get up without being dizzy? Can I go
Hmm.
to school? It's just the same order of importance as these other physical things.
Yeah. So I don't have a young child, so I don't know what's happening in schools today. I know that at some point we were very focused on physical health. We had food and stuff for kids. This is another part of it, right? I mean, it's not just physical health we are worried about. It's actually we might be more worried about mental health than physical health anymore, right? In schools.
I think that's true. I think that's also true in the labor market more generally. So it has been true for decades that the major cause of working days lost are mental health problems, not physical health problems. Mental health problems strike people of working age, and they take them out of the labor force for a long time
Hmm.
compared to most physical health problems. So yeah, I think mental health problems are a very important part of health promotion. And I think schools are under some pressure, particularly since the pandemic, that they're
Hmm.
supposed to be doing something about mental health, but I don't think it's clear to them exactly what that is, or
Hmm.
how best to do this. So should we have all the children doing meditation in gym class, or how exactly are we supposed to be addressing mental health? Now that's one issue. And then I think something that schools could do very constructively is address bullying. And
Yeah.
most schools have some kind of anti-bullying policy, or whether it's very effective or not, or whether the children really feel empowered to appeal to the anti-bullying policy is a different matter.
Yeah, I mean, it's not a deterministic problem. I mean, we are very good at diagnosing and treating physical problems, or at least we have gotten better at it over time. But mental health is still very uncertain, and it's very difficult to sort of have a heuristic-based implementation. That means that you need people interacting with the person. It's pretty time consuming, I would imagine, from a diagnosing perspective. And so, from a policy perspective, the question is are we to a point that we have to invest into it for teenagers and even younger kids? That we are now to a point that that is a significant health issue for kids. And if so, then how would you go about doing that? The solutions don't seem very attractive in any way. So, do you have any
Well,
thoughts on that? Yeah.
yeah, one thing that I'm quite interested in is some states have at least some schools that have mental health clinics in the school.
Yeah.
And by that, I mean a place where somebody, a lot of schools have a school psychologist or something like that. And the school psychologist is there to basically refer people outside, but not there to offer therapy right in
Mm.
the school and make it really convenient for people.
Right.
So, some kind of clinic where they actually offer therapy services in the school
Mm.
seems like it would have potential.
Yeah.
One evaluation I've seen of that was done in Minneapolis and showed some pretty significant effects in terms of reducing dropout and increasing educational outcomes, and also decreasing self-harm and further it's like exacerbation of mental health problems. But that's only one example. So I'm interested to know whether that applies more broadly.
It's a complex problem, and I can see from a cultural perspective. Let's say I have a psychologist on premise in a school, and he or she is going to see all kids next month. And then if X and Y are sort of sent out to somewhere, those kids coming back will have a lot of problems, sort of integrating with the rest of, I mean, people are going to attach stigma to this issue, right? So I don't know what the solution is. I'm just thinking through. Is that going to make this situation better, or it could even make it worse in some ways?
Yeah, that's true. It's not entirely clear, so that's why it would be good to have more evaluation.
Excellent. So I want to go into another paper. Administrative burdens and child Medicaid and CHIP enrollments. That's your paper?
Yes.
Okay. So you say here, following decades of increasing child access to public health insurance, pre-pandemic enrollments fell in many states after 2016, and the number of uninsured children increased. You say here the study provides the first national quantitative assessment of the role of administrative burdens in driving this drop in child health insurance coverage. Yeah, so I always wondered about this, Jared. So when I go meet with my primary care physician, most often he or she is spending so much time putting information to the computer, and less time actually interacting with the patient. So most providers say that administrative burden has increased quite dramatically. Um, but this is not the provider's administrative burden. You're saying, generally speaking, this regulatory burden is creating problems, right?
Right. So this is actually burden on people who want to get signed up for Medicaid.
Oh, yeah.
And
Okay.
the type of thing is, for example, do you have to re-enroll every 6 months, or can you re-enroll once a year? How much paperwork do I have to fill in? How much proof of earnings and things like that do I have to show? And some of it is like kind of hard to justify on a that there's some purpose to it, in the sense that they will just decide to send notices to everybody saying that they have to re-enroll, and if they don't respond, so this is mailing something to your house, right? Where they may have the wrong address.
Yeah.
And then if you don't respond within 10 days, you get cut off. And then there may be a punishment that if you got cut off, that you can't get signed up again for 6 months, something like that.
Is that the status quo, that Medicaid patients have to re-enroll every 6 months?
Well, it depends on the state. So this ends up being kind of a red state, blue state thing.
Okay.
Since all the states had to, or whether or not they adopted the ACA, Obamacare, Medicaid expansions, they still ended up expanding their Medicaid programs because there were other rules that had to be followed in terms of who got covered. So you saw increases in enrollment after 2014 in almost every state.
Yeah.
And then some states were very unhappy about that. So they essentially took measures to beat back those enrollments. And then in the paper, what we show is that had a negative effect on children, that they were less likely to be enrolled, and especially Hispanic children.
Yeah. Yeah, I mean, as you're reading through some of the abstracts of your papers, I was thinking there's a larger, I think you talk about this in some ways, a larger question of economics, which is what's the return in investing early to kids? And the return is almost infinite from the data that we can see, right? So all this politics, we talk about day in and day out about tactical cost, simply just doesn't understand sort of the long view of what this is going to come back to us, right? I mean, you get a healthy, educated kid into the world, that kid is going to pay taxes,
That's
for the conservatives. Yeah.
true. That's been shown actually with
Yeah.
the earlier Medicaid expansions in the 80s and 90s, that the children who gained Medicaid coverage and then were healthier to begin with were more likely to be working when they were in their 30s and were paying higher taxes. So I think, unfortunately, that a lot of it boils down to not economics, in the sense that people don't necessarily care what the data shows or whether there's a return. They just feel that the government shouldn't be doing certain things. So it's more of an ideological position. Only parents should pay for health care or something like that.
Yeah, but as you say in your papers, society has a great interest in this. Being an engineer, I think about this like an aircraft taking off. You have at a much higher risk before you get to the cruising altitude of, let's say, 35,000 feet. We're 100, 200, 300, 1,000. You're at a much higher risk for a variety of reasons. And humans are in many ways similar, you know. And you think about sort of prenatal effects on this as well. So this starts at conception in many ways. And if you can give good initial conditions to that child, uh, get him or her to 35,000 feet, then society is going to benefit from it hugely, right? So that is fundamentally what is missing, I think.
Yeah, I totally agree. I think one interesting thing, so there's a lot of work looking at prenatal conditions and early childhood, and adolescence has been comparatively neglected, but it is also a period when a lot happens. There's a sort of fundamental reorganization of the
They're tough
brain.
to deal with. I have to give you that.
Well, the physical changes, the mental changes. So I think it's also a period of opportunity for intervention. And so thinking about interventions that have been successful at targeting adolescents yeah, is also an exciting area to get into.
Yeah. So there's sort of a societal economics question here that is much broader than, how much money are you spending question. It's really about a return question. And I don't know if our politicians are good enough to understand this. So I don't have high hope, Janet, that we're going to get any better. Um, so I want to finish up with something I never thought about, the hidden cost of firearm violence on infants in utero. So you say you have firearm violence in a critical public health crisis in the US, marked by a significant number of homicides involving firearms, including indiscriminate shootings in public spaces. So I haven't looked at the data in detail. What is showing here is that when there is an event, whether it's some sort of mass shooting or something like that, you can then ex post measure the effect of that on pregnant women and follow that through. That is an amazing thing that that policymakers have to really internalize, right? I mean, this is not the cost that we haven't really internalized before.
Yeah, we do, in that paper, we look at two different things. So the first thing is the Beltway sniper attacks.
Yeah, in DC, yeah.
In DC. And an interesting thing about that was that the snipers were on the loose for 3 weeks. So it was a protracted period where people were very frightened, right? Because the people who were shot, it was very random. There were children, elderly people, men, women, doing all kinds of things. And so there's kind of a high level of terror. And so what we look at is women who were pregnant during that 3-week period and who lived close to where those shootings were occurring. And then we compare them to women who lived further away and who were pregnant outside of that window, either just before or afterwards. And we see that there's a 25% increase in very bad birth outcomes. So basically having a very premature baby, less than 32 weeks, or having very low birth weight, less than 1,500 grams. So that's kind of the first experiment. And then the second thing that we do is look at all the data on mass shootings and say if there was a mass shooting in your county that overlapped with the pregnancy, what impact does that have on infant health? And so we see, again, effects on low birth weight and very premature. So it's consistent with some of the evidence talking about how stress during pregnancy is bad for the fetus, but showing specifically that these events cause stress, and then that causes these negative effects on babies.
Yeah, I mean, you say here in conclusion, the estimate suggests the additional cost of $155 million in 2023 for the Beltway sniper, as you talked about attacks, and 75 million annually for mass shootings. And this is, in some sense, more of a tactical cost, isn't it? I mean, we're going to bring these kids into the world. Where do you end your sort of NPV horizon to get these numbers?
Oh, so those numbers are I think, very conservative, and they're conservative. We're taking the estimates of what it costs medically to have a low birth weight child, and we're also kind of assuming that the people who lived a bit further away weren't affected at all, whereas they were probably affected to some degree. So that gives us I actually don't, I have mixed feelings about that number, because on the one hand, people want you to put in a number, but I think that number really is a kind of extreme lower bound number.
It's a starting point. It will get people to think about it. So in conclusion, suppose we have a world, I don't think it's here, it's somewhere else, some extraterrestrial planet, and we are similar biological systems, humans, let's say, and we know all this data. How will you organize it to be sort of utility maximizing? I mean, we know, I mean, it's a it's a broad question. We know that, initial conditions matter a lot, so I think about life as sort of a stochastic phenomenon, right? So I mean, a lot of stuff is going to happen to you, to anybody. But if you have good initial conditions, you are better equipped to deal with stochastic jumps or, or the variations that you will see in your life. So given that, what is the best way for us to organize to optimize the system?
So I think we know, I'm not sure we know the optimal way to organize the system, but we know a lot of things that would be an improvement on the current system in terms of, quality prenatal care, quality early childhood programs. I guess there's more work being done on the schools in things like anti-bullying programs or mental health interventions. So I think shortly we will know more about how to intervene at those points. There's also the whole sort of literature looking at home visiting programs, and that those can have a positive effect. I think, for example, Denmark has a pretty sensible one in the sense that everybody gets a home visit or two, and then if they think that you're fine, then you don't get more, but if you need more help, then you get more visits. And so, that seems like a sensible thing in terms of providing support at a crucial point in time.
So let me ask you one last question, Janet. So I don't know if you have looked into this, do you find differences because of cultures? And I'm thinking Asian countries, Western countries and Eastern and Western Europe, they all have sort of different. I mean, Japan is very, very different. So do we see any difference in how these cultures deal with the same problem?
That's really interesting. I'm actually doing some work with some Chinese co-authors looking at the school system in Taiwan, which is one of these systems where there's kind of high stakes tests. And also culturally, a lot of emphasis on education.
Those kids are hardcore. I mean,
they get very good test scores on average, so they always are near the top of the TIMSS scores. But then the surveys of them also suggest, a lot of unhappiness. And so what we're seeing is when kids enter primary school and when they enter middle school, you see increases in use of psychiatric medications.
Oh, wow. Okay.
And then after they finish the high stakes testing to get into high school and then again to get into college, then it drops off. So you see, you put the pressure on, and then this is one way that people are responding, and then you take the pressure off and the problems go away to some extent. So it does show the cost, I guess, of having such high expectations.
And we know that suicide rates are quite high in some of those cultures. Japan is a prototypical example of this. And so, I mean, I don't know if there's any policy intervention here, but it seems to me that, so when you put that much pressure on kids, bad things are going to happen. And we see that in the Eastern cultures. Yeah, very competitive Eastern cultures.
Yeah.
Excellent. Yeah. Thanks so much for spending time with me, Janet.
Okay. Well, it's a delight. So thank you for asking me.
Thank you. Bye.
Bye.